today is a privilege for all of us. So thanks, Bill.
Oh, yeah.
Wait,
guys.
wait. One last thing. I just got a private text message that says best educator in dentistry. And who is that from? Marcos Vargas. So there, take it away, Bill.
Oh, that's awesome.
All right, you guys. I'm feeling a little overwhelmed here. So thank you for the beautiful words. Really, thanks so much.
This better be good.
Yeah, exactly. I'll live up to that. All right, so here we are at Act U again today. It's always a pleasure to be with my family, and holy cow, to hear so many beautiful words. Thanks to each of you guys. I love each of you. So this is my dental family that we're looking at Act U. But I have the pleasure of telling you that I'm in Dallas this weekend. I'm not in San Antonio because I'm celebrating my oldest grandson's 8th birthday. And I've got 5 grandkids, and all of them are here for the birthday party. And so we are partying this weekend. The one on the left is James. He's the littlest one. He's about 10 months old. And you can see he's a great one. And on the right are Cooper and Hudson. And Hudson is the one with the orange hat that is going to be 8 tomorrow. And he's got, those 2 boys have a great father, but he's not an outdoorsman. And so it falls to me to do the outdoor part. And so I'm the one that's getting these boys started on their hunting and fishing and camping adventures. And Hudson has really turned into quite a fisherman. He loves going. We'll go tomorrow. I'm not there today because of this, but we'll be going again tomorrow. There's a lake real close to their home, and so I'm the luckiest guy on earth, spending the weekend with my 5 grandkids celebrating the oldest birthday.
Now, I got to ask you this. Do you hear this? Like, those kids are so darn cute, and they all look like you. If you lost them in a crowd of 100, I could pick all 5 of them out. They all...
Yeah, the Robbins gene does come through relatively strongly sometimes. So I'm not sure I'm grateful for that, but I'm certainly grateful to be a part of the family. My wife is here, obviously. She's not in the room here. I'm in a hotel room. She's not here, but she's here this weekend. She gets credit for pretty much all of this, as most of our wives do. All right, so let's get into the show. The primary thing that I'm going to talk about today is digital smile design, although I'm going to touch a little bit into global diagnosis because obviously I can't talk without mentioning that. DSD is a concept that was given to us, at least in this official format that I'm talking about today, by a guy named Christian Coachman. And when I first saw Coachman speak many years ago, I thought, yeah, this is pretty cool. But, I set up some barriers in my mind that I'm going to talk about. In recent years, I've gotten to be friends with Christian, and he's an incredibly intelligent guy. I mean, he is a visionary, but he's also a wonderful human being. The one thing that's bad about it is that me and Coachman look a lot alike, and people are always getting us confused when we're at bars and things together. So Coachman is the one on the right with the asterisk. I'm the one on the left with the martini. So when I first started him to speak, I set up 3 barriers in my mind. The first was technology. I really wasn't interested in learning how to do a smile design on a computer. This is like 6 years ago, because you had to know how to do either Photoshop or really by that time it was Keynote to do your own smile designs. I didn't want to do that. The second barrier I set up in my mind is, do I really need it? I mean, I've been talking about smile design now for 30 years and I'm reasonably good at it. Do I really need it? Well, it turns out I did need it. I'm way better than I used to be because of it. And the third generic barrier that I set up in my mind was change. Change is just hard. And when you go to a course and you hear something that's cool, you have to make a decision as whether you're going to go home and do anything about it. And change is just hard, especially the older that you get. But I eventually, about 4 years ago, decided to incorporate DSD into my practice, and it's been a game changer for me. Not only has it made me better as a diagnostician, but it's brought some fun back into my life that wasn't there. So when Bob and I were talking earlier when we just got on the site this morning about, it's hard to practice dentistry 4 or 5 days a week. It really takes a toll. And sometimes bringing something new like DSD into it brings a breath of fresh air into your life professionally. In order to be a DSD dentist, now when I'm talking about this, I'm talking about using a digital smile design lab, and I'll talk about that next. You can do a lot of this on your own. You can do a lot of this with your local laboratory. So it's not like you have to use a DSD laboratory, but I'm going to present it that way because I think they have a wonderful system set up. So there are 3 requirements. The first requirement is you have to have a DSD certified lab. The second, you have to be able to make 5 specific photographs. And the third, you got to be able to email them to the laboratory. So let's talk about the laboratory. The DSD Planning Center is in Madrid, and it is a large lab that has the capability of doing planning and also doing dental appliances for you. So you can get a lot more done at the DSD Planning Center in Madrid than just the smile design. So if you are not yet part of this system, then all you do is go to DSD Planning Center, and this will come up. And if you're not registered yet, you can see a box that says to register. They are very user-friendly, and they will be very helpful to you, leading you through the process of setting up your account and getting your first case sent to them. It's not very difficult. The older you are, it seems the harder it is. And I'm probably the oldest guy on this program today. And if I can do it, everybody can do it. All right. So after you've got your planning center set up, you then need to be able to take 5 photographs. So let's look at Elizabeth. This is a case we're going to go through from beginning to end. The first 2 photographs that are required are full face repose and full face full smile. And they need to be framed from the front because one of the powers of the DSD system is the ability to overlay different images. So we can't be taking these photographs from above or below or from the right or from the left. They need to be taken straight on. Those are the first 2. The third and the fourth are the same photographs, but they're done in profile, repose and full smile. The 5th photograph is the oddball one that I never took before, but I now certainly see the value in it. This is a required photograph. It's called 12 o'clock shot. It's taken from behind. You can't take it from in front. I prefer to take it from behind. So I have the patient lay down almost flat in a supine position. I shoot from behind. I parallel the eyes with the viewfinder, and I shoot over the nose so that I can see the incisal edges of the maxillary anterior teeth in full smile. This is a very important photograph that must be done correctly. There are a couple of additional photographs that I think are very helpful to the DSD designer. The first one is on the left, and that is retractors in with the patient parallel to horizon. You can see her interpupillary line is parallel to horizon, and it gives a very good view of the fact that she's got a canted maxillary occlusal plane. I think the other additional photo that's helpful is this one where we zoom in on the lateral view and we get a real sense about the verticality of our maxillary anterior teeth. All right, so we're going to make these photos and then we're going to download them into the DSD Planning Center app that's available to us. So the next question that Coachman has made very clear to me over these last 4 years is that a really good full smile photograph on the right? Now, I've been doing dental photography my whole career, and that's approaching 50 years. And I've done a lot of photography through the years, and I'm no expert, but I'm reasonably good at it. And I would say that's a good photograph, a good full smile photograph. You can see that we see a lot of teeth in the photograph. You can see there's a fair amount of tension in the mentalis muscle. You can see that there's a pretty good fold in the upper lip. I would say that's a pretty good full smile photograph. Well, Dr. Coachman challenged that idea for me because he said we cannot predictably get an accurate full smile in a photograph by just asking the patient to go into full smile. He proposes that we need to actually make a video. So this is something I'm doing routinely today in my practice. So I just take out my iPhone and I ask her to go into a full smile. And when she goes into a full smile, she goes about the same place she went in the photograph. Now I'm asking her what she had for lunch, and my goal is to make her laugh. My goal is to capture her in a laugh.
I know, I'm saving it for later.
And there it is, right there. So I got her to go in an animated full smile. Now, all I have to do is to download that video on my computer. I can do a screenshot of that one screen, of that one specific part of the video, and I now have a more accurate view of this patient's full smile. So look at my photo and look how much animation I could get when I asked her to go in full smile on demand, and look how much more she gave me when she was doing it in a smile and an animated laugh. So I agree with Dr. Coachman that we cannot predictably capture a full smile with a photograph. We need to video our patients if the full smile position matters, and it almost always matters. We then have to finally couple that with StudyCast. We have to have the photographs and the StudyCast. If you've got a scanner, then all you do is send the STL files. If you don't have a scanner, then you make Alginate impressions, you pour them in stone, and you get one of your buddies to scan those two casts. And then you send those files to the laboratory, and now they have everything they need to do the DSD design. So you do not have to have any technology in your office to be a DSD dentist. All right, so we're now going to download the images that we just looked at, and we're going to send them to the lab and ask them to do a smile design for us. And what they're going to do is they're going to design the patient's smile based on a set of 10 guidelines that Dr. Coachman teaches. And his guidelines in smile design are almost exactly the same with mine and global diagnosis. So each of those lines has a meaning, and the lab technician that's doing this design has learned this from Dr. Coachman's system. They're going to overlay the scan of the maxillary cast into the patient's head using that 12 o'clock shot. That's why the 12 o'clock shot is so important. They're now going to start the smile design. And they're going to use the same parameters that we all know. The maxillary central incisor should be 10 to 11 millimeters long. It should be 80% as wide as it is tall. We'd like the upper lip to be at the gingival line and the lower lip to be on the incisal edges, and so on. It's all of those parameters that we've all learned in smile design. And what they propose with their smile design using digital wax. So this is all done 2D digitally on the computer. So using gray digital wax, the technician proposed that in order to idealize her smile, we needed to go up about 1.75 millimeters and down about a half a millimeter in order to make a normal length tooth in the correct position in her face. So that is the proposal. Now, they're not telling us how to get there. All they're saying is this is where the teeth need to be in an idealized smile. That's the way it looks. So you're going to get this back in a few days in a slideshow from the DSD Planning Center. There's going to be 15 or 20 slides that show you what the proposal is. And when I got this back, I thought the right side looked pretty good. The anterior looked pretty good. But I felt like it needed to go higher on the left side because she's got a cant up on the lip there. So this was the proposal the first time. And they proposed that we're going to cover about 1 millimeter of gingiva with the tooth. Again, they're not telling us how to do that. They're just saying that's where the tooth needs to be. So I sat back and said, I want to go higher on the left side. So this was the second project. And you can see that they've gone higher on the left side than they did the first time. Excuse me. You can see that we've doubled the amount of gingiva that's covered compared to the first time. So I'm going to tell you that almost every time I send a case to the DSD lab, essentially I'm never totally satisfied with it. Almost 100% of the time, I'm going to ask them to make changes in the design to suit me. And they're very easy to do that. They're happy to do that. So I okayed project 2, and so now we're ready to move forward. Now, the thing I want you to notice on the left screen is that that wax is just being added to the facial surfaces of the teeth. It is not a true diagnostic wax up. It is an additive wax up, and it's only good for one thing, and that is to make a motivational mock-up in the patient's mouth, which is what we're going to talk about in a moment. This wax up is no good to make provisionals. It is for diagnosis only. Here's the magic, where the magic begins. They now take that 2D design that you've okayed and turn it into a 3D design and print it. You don't have to do this. They're going to do this for you. However, if you want to print it yourself, they will just send you the files back and you can print it yourself. So you now have a 3D representation of the 2D proposal that you saw on the computer screen. And this is really where the magic begins, because they will make a matrix for you, or you can make it yourself out of PVS material. And this matrix is going to be trimmed very precisely to be right at the edges of the teeth gingivally. Remember, we added about 1.75 millimeters of wax up over the gingiva. So this matrix is going to be trimmed right to the top of that diagnostic wax up, very precisely. There are a couple of limitations to doing a motivational mock-up in the patient's mouth. If the patient has a significant skeletal discrepancy like vertical maxillary excess, you can't fix that with a motivational mock-up. That has to be done on a computer. Also, if the patient's teeth are really procumbent, really coming very far forward, then you can't do this additive diagnostic wax up in their mouth and show them that it's going to look pretty, because they're going to look like a horse. Their teeth are going to be too far forward. So let's do one. This is one of the first that we ever did. So I'm drying the teeth. Now, you're not going to have cheek retractors in. Those are just so you can see what we're doing. So my partner is adding Visacryl to the matrix. And you don't need a ton of Visacryl, and you don't need to go to the second molars. This is really too much. We don't need that much, so don't put that much. Holy cow, don't put more. All right, so that's way too much Visacryl. That was one lesson. We're now going to seed it. It seeds very precisely in the patient's mouth. And once it's seeded, you'll see the flash coming out on the facial. Notice that she flinches. That's because of the cheek retractors. There is no discomfort related to this matrix in the mouth. Those of you who know me know that I'm not the most patient person on earth, and poking at soft Visacryl doesn't make it set up any quicker. So just stand back from the patient for 30 seconds and relax and say, "Om." And then 30 seconds later, it will start to gel. Once it starts to gel, as we start to see right there, I can now peel it off right at the edge of the matrix in large pieces. And so that's the good news of this. I'm not going to do any finishing of this in the mouth. I'm going to peel all of that off and pick it off in big pieces. I'm then going to leave it in an additional 3 minutes so that it's in the mouth a total of 3.5 to 4 minutes. I'm then going to remove the matrix from the mouth, and this is the way it looks with no other work. I've done nothing to make this look better. This is just the way it looks with the matrix out of the mouth. So when it's trimmed, when the matrix is trimmed correctly, it comes out beautifully right out of the mouth. Here's something you never want to do. Coachman teaches very clearly, you never want to hand a mirror to a patient, because if you do, what they'll do is they'll put the mirror up close to their mouth and they'll start looking at all of the little deficiencies in the motivational mock-up. This is supposed to be a positive, really fun experience for the patient emotionally. So we don't want to give them a hand mirror. We want to show them what we've done using photography. So I'm going to make photographs of the patient, and then I'm going to download them and show them the result of the motivational mock-up using photographs, not using a mirror. There's another way to do it today, which is really easier. There's an extra expense to this, but it's probably worth it because it takes less time in the mouth. So once you have the DSD design done, you can ask the DSD lab to make you a shell. And that shell will fit over the teeth. And all you do is to place a little flowable on the inside of each of the teeth in the shell, stick it on the tooth and light cure it. And then you've got your motivational mock-up in the mouth in less than 30 seconds. There's no cleanup associated with it. So using a shell is really a nicer way, but a little more expensive way than using what I just showed you with the matrix. So this is a shell back from the laboratory. It comes in 3 pieces. 6 through 11 will be 1 piece, and the premolars will be a piece. Or it may be the premolars and the canine with only the 4, but it will come back in 3 pieces. So all you do is take a patient, and this patient's goal was to have a broader, brighter smile. She wanted it to be broader, but she wanted it to be brighter also. So now we just in 30 seconds put in the shell, and now we do our photographs and show the patient what the possibilities are. This is another one. This is a patient that we're doing a little more dentistry on than the last one because this patient has a significantly greater problem. So we're going to go up over the gingiva on the maxillary anterior teeth on the right, and we're going to blacken out the edges because you can take a Sharpie and blacken the edges, and when you take a photograph, you don't see those edges hanging out below. So I got a little carried away on this one, and I blackened out the incisal edge of the lateral too much, and you'll be able to see that you can see the darkness showing through it. However, back at a photographic distance, you don't notice the darkness of the incisal edge of number 8 below because it's been blacked out. The mistake was that I got some of the black marker on the tooth underneath the shell, and so that darkness showed through. So that's a mistake you don't want to make. But once again, you can very quickly give a patient a vision of what the possibilities are with this motivational mock-up, either directly in the mouth or with the shell. So there's what I show the patient. There she is pre-op on the left. There she is with the motivational mock-up on the right. So what do I have here? What do I do next? Well, I do have a beautiful smile design that was provided to me from the DSD lab, but I don't have a diagnosis and a treatment plan because that's not what DSD is for. They are not there to diagnose and treatment plan your case. They are there to help you with an ideal design. That's where the global diagnosis comes in. And I'm going to give you a very quick Cliff Notes version of global diagnosis.
Hey, Bill, before you start that, can I just ask a question?
Yes, sir.
With DSD, can you also have them send you just the digital file of the mock-up and then you can print a model in your office or print your own shell or something like that?
Absolutely. And that takes the cost of this down significantly. So yes, you can absolutely have them just do the design, and let's just talk about the numbers a little bit. I can't remember exactly, but I'm going to give you a rough idea. For them to do the design for you, it's going to be maybe $100 to $150 because it's in euros, and so it kind of depends on what the exchange rate is. But just the design itself is $100, $150. If you have them do everything else, print the model, make the matrix and all, it goes up $500 to $600. So there is a significant savings if you let them do the design and you do everything else. Does that answer it, Darren?
Yes, sir. That's exactly what I thought.
Okay, so these are the 4 global diagnoses that dictate all interdisciplinary treatment planning. Now, that's a big statement. How can I say that? Well, it turns out that there are only 5 things that you can fix as a dentist. The first thing you can fix is the landscape with an emphasis on the lips. The second thing you can fix are the teeth. The third thing, the gingiva. The fourth thing is the alveolar bone. And the fifth thing are the skeletal bones. And at the end of the day, as a dentist, you can only fix these 5 things. And if one of those 5 things is incorrect in the patient, the global diagnosis system tells you why it's incorrect, and it gives you a diagnosis. And once you name it, then you can treatment plan it. And that's the power of the system. In order to make a global diagnosis on a patient and determine which of those 4 diagnoses the patient brings to you, all you have to do is to ask and answer what Jeff Rouse and I call the 5 core questions. And here they are: face height, lip length and mobility, the gingival line in relation to horizon, the length of the maxillary central incisor, and can you feel the CEJ and the sulcus? This is what we call the 5 questions. So question number 1, face height. We know that the midface and the lower face should be 1-to-1 in the proportional patient. Midface is measured from mid-brow point to under the nose. Lower face is measured from under the nose to under the chin with lips slightly apart in a reposed position. The second question is the lip length and mobility. We know the average lip length measured from under nose to wet dry border is 20 to 24 millimeters. And we know the average lip mobility from repose to full smile of the upper lip is 6 to 8 millimeters. The third question, the gingival line in relation to horizon. On the upper, we see a straight gingival line as the way it's supposed to be in the normal patient. In the lower, we see a curved gingival line. The teeth have supererupted, and as they supererupt, they bring bone and soft tissue with them, resulting in a curved gingival line. That's diagnostic for the third global diagnosis, which is dentoalveolar extrusion. Now, I'm showing this to you in the anterior maxilla for 2 reasons. First of all, it's the most common place that it occurs, and secondly, it's the easiest place to see it photographically. However, we can have dentoalveolar extrusion anywhere in the head: upper jaw, lower jaw, front teeth, back teeth. We diagnose it based on the gingival line in relation to horizon. The fourth question is the length of the maxillary central incisor. And we all know the average maxillary central incisor is 10 to 11 millimeters long. And the fifth question, can you feel the CEJ and the sulcus? In the normal patient, you can. In a patient that's got altered passive eruption, you cannot. So all we have to do is to ask and answer these 5 questions to make a global diagnosis on any patient. So let's go back to Elizabeth. On the left, to remind you what the normal numbers are. On the right are Elizabeth's real numbers. So let's look at them. Her face height is 1-to-1. That's normal. Her upper lip is 22 millimeters long. That's normal. Her lip mobility is 10. That's abnormal. Her gingival line is canted down. That's abnormal. Her maxillary central incisor is 8 millimeters long. That's abnormal. We should feel the CEJ and the sulcus, but we cannot in her. That's abnormal. So we've got a normal face height and we've got a normal lip length. Everything else on Elizabeth is an outlier from normal. And based on the answers to those 5 questions, I can now make a global diagnosis on her. And I would assume everybody watching can also. She's got a hyperactive upper lip. She's got dentoalveolar extrusion with wear and a cant, and she's got altered passive eruption because she's got a short central incisor, and I cannot feel the CEJ and the sulcus. So there's my global diagnosis: hyperactive upper lip, dentoalveolar extrusion with wear and a cant, and altered passive eruption. Now that I've got diagnoses, I can make a sequence treatment plan. So this is my plan for Elizabeth. We're going to do aesthetic crown lengthening as far back as we see. So it's going to go from the mesial of number 2 to the mesial of number 15. We go 1 tooth distal to the distal extent of the smile. The next thing we're going to do is to pre-orthodontic bond this patient. Our rule today is that when a patient with wear goes into ortho, either before the appliances go on or during the ortho, we're going to make the teeth anatomically correct with composite. Most of the time today, we do it before the braces go on. Because if we make the teeth anatomically correct with composite, then the orthodontist knows exactly where the teeth need to be moved. So at the end of ortho, they'll be in the correct positions for me to do my porcelain restorations. After the pre-orthodontic bonding, we're going to level the patient orthodontically with Horizon, and then ultimately we're going to do veneers. So this is the day I did the crown lengthening. We're moving the bone up in the range of 2 to 3 millimeters apical to the CEJ, dependent upon that patient's biologic width. That's another discussion for another day. We're going to allow her to heal after the aesthetic crown lengthening for about 3 weeks. At 3 weeks, I'm going to go in the morning and do the pre-orthodontic bonding. So you can see I've made the teeth anatomically correct with composite. They were 8 millimeters long. They're now somewhere between 10 and 11. However, I am not leveling the composite bonding with Horizon. I'm just, if there's a cant there, I'm just accentuating the cant actually by making the teeth longer. The orthodontist now knows exactly what he or she needs to do in order to get my anatomically correct teeth in the correct position in the patient's face.
Bill, there's a question about what is altered passive eruption. Could you give a 30-second explanation, please?
Oh, thanks for the question, Mark. Altered passive eruption means that some of the enamel, the necks of the teeth, are covered with gingiva. That's one of the etiologies of a short tooth. The tissue and the bone did not move up correctly. Generally speaking, the alveolar bone should be approximately 2 millimeters apical to the CEJ, and in patients with altered passive eruption, the bone doesn't move up away from the CEJ, and it's too close to the CEJ, and if the bone is too close, then the tissue cannot apically migrate. So the treatment for altered passive eruption is to move the bone up into its correct position and then move the tissue up also. So there are only 3 reasons for short teeth. The first is microdontia, like a peg lateral. The second is incisal edge wear, and the third is altered passive eruption. And the way that we know a patient has altered passive eruption is that we feel for the CEJ and the sulcus, and in a normal patient, you can feel it. In a patient with altered passive eruption, you cannot feel the CEJ and the sulcus because it's hidden up underneath the attachment apparatus. So hopefully that will take care of that question. All right, so this is actually 3.5 months into ortho. And I think you can see by the use of these skeletal anchors devices, these 4 TADs in this patient, my orthodontist, Dr. Norris, was able to level her maxillary arch with Horizon in 3.5 months. That's amazing, because in the old days, we could not level a canted maxilla. The only way we could do it was with orthodontic surgery. But today with skeletal anchorage, we can routinely level canted patients. The hard part on this patient is not leveling her cant. The hard part is getting her posterior teeth into the correct places, occlusally, because we're not doing a restorative dentistry on the back teeth. So it took a year more after she was level with Horizon to get her posterior occlusion correct. So it took Dr. Norris a total of 15 months to move this patient into the correct positions for me as the restorative dentist. So this is after the patient has been leveled with Horizon. You'll notice the composite bonding is still there. It was there throughout the orthodontic treatment. That's what directed Dr. Norris to put the teeth in exactly the positions I needed them in to then come back and do my restorative dentistry. So there she is pre-op, and there she is post-ortho after the appliances have been removed prior to the restorative dentistry. So this is after we've done the EMAX veneers number 4 through 13 on Elizabeth. And it obviously helps to have a wonderful treatment team. And Dr. Tito Norris is one of the best orthodontists in the United States, and I'm privileged to be able to use him in San Antonio. And Hero is a laboratory technician that I'm using a lot today for my porcelain veneer restorations, and he has a laboratory in Boston. So I have a wonderful team supporting me in my restorative dentistry practice. So this is Elizabeth before and after, and this is a classic DSD case from beginning to end. Are there any questions on this one before we move on, you guys?
No.
I don't see any. No.
All right. The next thing I want to talk about is the power of the motivational mock-up. There are a bunch of great things that come with doing a DSD case. One of the most powerful is the motivational mock-up. So I'm going to spend a little time telling you how important this is in my practice today. Now I'm going to repeat. You don't have to send all of this off to a DSD lab. You can do this yourself. If you've got a scanner in your office, you can do the digital wax up on the scanner. If you don't have a scanner, you can sit down at your laboratory bench, or you can have your laboratory technician do an additive wax up. If you want them to go up over the gingiva to cover the gingiva, then you tell them that's what you want them to do. If you want them to lengthen and size the edges. This doesn't have to be done by a DSD lab, but that's what I'm showing you in this presentation today. So they're going to do the design, they're going to make the matrix for me, and then I'm ready to go. The power of the motivational mock-up is that it's not abstract. It's real in the patient's mouth. So this is Gloria. She came to me requesting aesthetic dentistry. So I'm not trying to sell this lady on aesthetic dentistry. She came asking for it. However, she thought she only wanted restorations on her 6 upper anterior teeth. And I had to help her realize that we couldn't give her the smile that she wanted with 6 upper anterior teeth. It would require 10. We would have to go to the upper second premolar on either side. What I used to do in my practice for many years before DSD is I would show her the photographs of another patient that I've treated with a similar circumstance. So here's a lady who's got anterior teeth that aren't so pretty, and we've done lots of porcelain on her. And I would show these photographs to Gloria and say, this is what we could do for you. But the problem is that Gloria knows she's never going to look like this patient, even if I do her teeth. This is an abstract way of trying to communicate with a patient, and it doesn't work very well. Now, we could do this on a computer, and we could simulate on a computer what this would look like, and we could certainly make it look more natural than that. But no matter how natural it looks on a computer, it's still abstract. It's always abstract until we put it in the patient's mouth. And when we put it in the patient's mouth, in 4 minutes, she now has a representation of what my vision is for her. And she also understands that we cannot do this by doing 6 front teeth. It's going to have to go back to the second premolar on either side. So the motivational mock-up has become a primary device in my practice today to help me better communicate with my patients. So let's look at Travis. Travis is actually one of my son's best friends. And I haven't treated Travis as a patient. I've actually used him in courses that I've done in the past where I've done motivational mock-ups live. So we're going to do a motivational mock-up on Travis, but we haven't treated him as a patient. The motivational mock-up works really well for people with small teeth and short teeth, and that's exactly who Travis is. So we take our first 2 photographs before, we take those 2, our 3rd and 4th. We take our 12 o'clock photograph. We can see some other things on Travis. He's got a retained primary canine. He's got spacing. He's got short teeth. He's got several things going on that fit beautifully into our global diagnosis system. We send some additional photographs. And this photograph of the retractors in is really helpful because it shows how his posterior occlusal plane dips down. And it also is a pretty good indicator that we're not going to be able to fix him just with crown lengthening. It's going to require more than crown lengthening to fix him. So there he is with his full smile. So we send his information off to the DSD Planning Center. In a few days, we get back this slideshow. And in this slideshow, they have idealized Travis's smile in the context of his face using an additive wax-up technique. So there it is on the cast. They're now going to print that cast and turn it into a 3D representation. And I didn't like the first time they sent it back. I felt like the tissue was too low, especially on the left side, the posterior. So I asked them to raise it. That's the second time. So I think we would agree Project 2 looks better than Project 1. So when they moved the gingival line up in the posterior in Project 2, the teeth still have to be the correct length. So now there's more tooth structure that's uncovered. That's what I'm going to blacken out with my Sharpie in the mouth so that when he smiles, you don't see that tooth hanging down. So let's look at Travis from a global diagnosis point of view. His face height, lower third, is a little bit long compared to the middle third. So he may have a long maxilla. He may have a little vertical maxillary excess. His lip is a good length. His mobility is good. He is down in the posterior. He's got a gingival line that's curved down in the back, so he has dentoalveolar extrusion in his posterior teeth. His central incisors are 8 and 9.5 millimeters long, and I cannot feel the CEJ on most of his front teeth. So the only thing that's normal about Travis is his normal lip and his normal lip mobility. So that leaves me with 4 possible global diagnoses. Perhaps he's a little bit vertical maxillary excess. He definitely has dentoalveolar extrusion in the posterior. He's got altered passive eruption in the anterior teeth because I cannot feel his CEJs, and he's got excessive buccal corridors. So this would be my treatment plan. I would first of all do aesthetic crown lengthening. I would then do orthodontic intrusion of the maxillary posterior teeth. I would then have to do onlays on the maxillary posterior teeth for occlusal purposes. I would then have to decide what I'm going to do with number 6. And I've got a number of options on number 6, and I have a strong feeling about what I think is the best, but I'm not going to get into that right now because that's not my topic for today. And then ultimately, we would do veneers on the anterior teeth and some of the posterior teeth. So let's do the mock-up on Travis. So there he is in his full smile and his repose. And there he is 4 minutes after the motivational mock-up. And the cool thing about Travis is that he's got amazing eyes. And some of you may have noticed this, but we tend to get drawn in to his teeth and we tend not to look at his best feature, which is really his eyes. But once we see how beautiful his teeth look, they're no longer a detractor, and now we have the ability to see the beauty of his eyes. And it only takes 4 minutes to get there. That's the beauty of doing the motivational mock-up. And if we did this with a shell, it would take 30 seconds instead of 4 minutes. So I'm going to introduce you to Tony, one of my favorite patients, and he's actually still in active treatment today. We're not finished with his restorative dentistry yet. So we send his case off to the DSD lab, and they're going to do a mock-up for the motivational mock-up, but they're also going to do a diagnostic wax-up for functional purposes. And we're going to see more of that in a few moments. So that's the proposal. That's where we propose to be at the end of treatment with this patient. So I'm going to get a matrix made of the upper printed cast and a matrix made of the lower printed cast, and I'm now ready to do the motivational mock-up on my patient. So this is the photograph of Tony before, and this is the photograph of him after the motivational mock-up. So the day I presented this to him, I had my son do a video. So I'm going to show you the presentation of the motivational mock-up to Tony. So I'm sitting in my office and I'm just sitting at a computer, and when he sits down, he's just going to see the pre-op photograph. And then I'm going to hit the button that puts the post-op photograph up. And I want you to notice what he does. I want you to notice how he reacts to what he sees on the computer screen. So that's the before.
This is the way it looks. Oh my God. Oh.
What do you think? What do you think about it?
Oh my God.
It's still in its mouth right now.
Totally different. It's a miracle.
If you can hear that, I don't know. He said it's a miracle.
It's going to take us a while to get there. Okay.
But now you've got a vision, and I got a vision what this all look like, and where it's at. And that'll help you remember. This will help you when you're getting all the work done. You'll remember this is where we're going to be.
This is where we're going.
Yeah.
I'm so excited.
Well,
I'm so excited.
He's saying, I'm so excited to get started.
Thank you so much. Thank you.
You're welcome. So the only disappointment in Tony is that he didn't cry. He almost cried. So I don't like tears in my office very often because usually that's not a good thing. But I love it when I'm doing a motivational mock-up. So that's the reaction that I normally get. When I show the photograph of the patient, they normally lean into the screen and their eyes get as big as saucers. They then lean back, they look at me, they then lean back and look again. It's the most favorite time in my practice when we do a motivational mock-up. So let's look at another patient. This is one of my favorite patients. She's been a patient in my practice for more than 20 years. We are on a first name basis. She actually cuts my hair. She comes to the office and cuts my hair about once a month. So we've developed a very nice friendship through the years. My wife is a dental hygienist, and she was cleaning Stephanie's teeth one day a few years ago, and she knows her very well too. We're all friends. And she said, Stephanie, holy cow, you've been coming to see Bill for 20 years, and why don't you let him fix your teeth? And Stephanie said, I can't believe you just said that. She said, I've been thinking about it. I just didn't know how to bring it up with you. So sometimes all you have to do is to ask and open the door. And she said, what do I need to do? And Brenda said, I'll go get Bill and bring him in. And so I came in. She said, I'd like to talk to you about the possibilities of making my smile prettier. So she's the perfect candidate for the motivational mock-up. So we make the photographs that same day. We send them off to the laboratory. The laboratory does the design. We can see the one on the bottom is a little better, the 12 o'clock shot, because I get more of the incisal edges of the maxillary anterior teeth. That's the way her teeth look. A few days later, I get the design back from the laboratory. They always are the same. I mean, you get these same lines. The slideshow that you get back from the lab is going to give you the same photographs every time. I'm not going to show this to a patient. This is silly looking. The purpose of this is for me to see what their vision was as to where her teeth should be and her smile. Okay, so they've overlaid the maxillary cast into her face to do the wax up using the 12 o'clock shot. So once again, it's an additive wax up. We can't use this for provisionals. This is only for the motivational mock-up. So the proposal on this patient on Stephanie was in order to idealize her teeth and her face, we needed to go up about 1.5 millimeters, and we needed to go down about 1.5 millimeters to get teeth that were the correct height to width ratio. So there's Stephanie before, and there she is with the motivational mock-up in. Early on when I was doing this, Dr. Coachman used to say, you want to use a color of Bisacryl, it's approximately the same color as their teeth, because there'll be thin areas and the teeth will show through, and if the Bisacryl is too light in color, there will be little dark spots in it. Well, I disagree with that today. I think it should have been brighter. So today I use a really bright Bisacryl when I do this, so when they go into full smile, it really pops. So her teeth look pretty, but they're not as bright as I would like. So there she is before, there she is after the motivational mock-up. And almost always they say, can you really do it? And that's the fun part, because the answer is, yeah, I really can. So Stephanie said yes. So if we'd done a global diagnosis on her, we would all know that she's got altered passive eruption, because I could not feel the CEJs and the sulcus. So we first of all did aesthetic crown lengthening on her. 2 months later, we're now ready to start doing some mock-ups. Now, we're not doing our final preps for several months. I like to wait 6 months from crown lengthening to restorative dentistry. So there she is pre-op. There she is with the motivational mock-up. And there's her question, can we really do it? And the answer is, yeah, we really can do it. Now, I want you to think about this for a minute. When does this fit into my practice? Well, I see a patient for a new patient exam, and I see that they have real possibilities for significant improvements restoratively, both functionally and aesthetically. So I ask them about their goals, just like you do. And if that's a patient that is open to the idea of doing comprehensive dentistry, then I'm going to make the photographs and the scan the day that the patient's in on the new patient appointment, and I'm going to send it off. And the patient's going to come back in a couple of weeks, and I'm going to do the motivational mock-up before we ever talk about a treatment plan. And when we're in the room, in my consult room, looking at the pre and post motivational mock-up, and the patient's eyes are as big as saucers, it's at that point when I start talking about the treatment plan. So I'm presenting the information from the motivational mock-up before I'm presenting a treatment plan. It puts me in a very powerful position, because the patient sees what the possibilities are, and then I can tell them how we get there. Now, one thing I really like about Coachman is that he spends a fair amount of time talking about integrity. And clearly, you could manipulate a patient into something they don't need using a motivational mock-up. So I think we have to be clear here that we're using this motivational mock-up to help demonstrate to a patient what the possibilities are with integrity, not in a way that we're trying to manipulate a patient. So there she is after the restorative dentistry is done. She's now 73. She cut my hair last week, and she's still very happy with her restorative dentistry. And essentially, the reason she got the restorative dentistry done is because my wife offered it to her. All right, so we're going to finish up this discussion today with a long case. And I think this is a great case for many reasons, but it's not completed. So I'm not going to be able to show you a completed case, but I chose to pick this one other than other cases because I think it's got much more in terms of its ability to teach us. One of the things I love about this case is that many people believe that I have some type of special practice, because when I'm lecturing, I show very little single tooth dentistry. All I show is comprehensive dentistry. And so it would be a reasonable assumption for most of you watching that that's how my practice is, that primarily all I do is big fancy dentistry on rich people. Well, nothing could be further from the truth. My buddy Margis and I laugh about this all the time. He and I are both blue-collar dentists to a large degree. And I know what I do in my practice, and about 75% of what I do is single-tooth dentistry. So day in and day out, I'm doing single crowns and posterior composites. That's what I do to make a living. But about 25% of the time, I get to do this more comprehensive dentistry, which is what really still lights my fire. It's what still brings me in and brings me joy in dentistry. So the thing I love about Maria is that she is not the CEO that comes in and is ready to have a full mouth rehab. She actually lives 2.5 hours south of San Antonio in Laredo. She's a retired teacher, and she doesn't own a car. So when she came to see me the first time, and as she continues to come to see me, she rides a bus. So if I want to do comprehensive dentistry on a patient that comes to my office on a bus, I've got to figure out a way to make it happen. And if a patient has a high dental IQ and a high desire for really well done dentistry and moderate to minimal ability to pay, then I feel like it is my responsibility to figure out a way to make that happen. And one of the ways to make that happen is the way that Dr. Margis and Vargas have been teaching us for all these years, and that is to segment the case with composite first, and then perhaps yes or perhaps never go into porcelain. So that's what we're going to do on Maria. So Bob, this case is dedicated to you because you're the one that has taught me and many others how to do this. So Maria, a retired school teacher, 2.5 hours from San Antonio, rides the bus. She's fairly healthy. Her cutaneous lupus is not an issue for me as a restorative dentist. The only other thing is that she reports some snoring. Otherwise, she's a healthy patient. These are her chief complaints. She's got severe tooth wear. She's very concerned about the aesthetics of her smile. And this is the one we all hate to hear. She has 3 different bite positions. When I say, Maria, I want you to bite together, she goes, where? Which place? So we know that not only do we have a bunch of wear, but that we don't have a home position that she's comfortable in. That defaults her into a much more complicated patient. This is her dental history. She's had sporadic dental care through the years. She's visited several dentists, and she hasn't found a solution in her mind to her problem. So I'm the 3rd dentist in this round that she's talking to, trying to decide what to do. These are her treatment goals. And these are the treatment goals of most of our normal patients. I want a beautiful smile, I want a comfortable bite, and I want my teeth to stop wearing and breaking. So she is a normal patient with normal expectations. All right, so we look at her smile. And in full smile, she can't get all the way up to the gingival line of her teeth. Even though she's got wear and erosion, we can't see the gingival line of her teeth. And in fact, her incisal edges in repose are 3 millimeters up underneath her lip. This is a very difficult starting point for me as a restorative dentist. To have a patient that's about 60 years old and has -3 incisor display in repose. So once again, we take our good photographs that show us that her teeth fit together like the teeth of a gear. And we can see that she's got dentoalveolar extrusion all over her mouth. So we know that's going to be one of our global diagnoses. Dentoalveolar extrusion with wear. We look at the occlusal surfaces, and we can see that there's wear in the front and there's wear and erosion in the posterior also. We look at the cast, and we can see even better, I think, in some ways, the issues associated with her oral health. And I think if you've noticed, her oral hygiene is actually very good, and yet she has all of this negativity going on in her mouth. So what else would you like to know about Maria that I haven't told you yet? And I would hope that one of the things you would want to know would be the answers to the 5 questions. So let's go through the answers on Maria. Her face height. Lower third is significantly longer than the middle third. But how much is significant? It's going to be, I think, in the range of 3 millimeters. So we have a diagnosis that goes with the long lower third of face, and that diagnosis is vertical maxillary excess. But that's not what Maria has. She doesn't have a long maxilla, because remember, we can't even see her incisal edges in repose. The second thing is the lip length. And if you just look at her, I think most of us would say, just by looking, it looks like her lip is long. And the answer is, yes, it is long. It was 26 millimeters long. And the normal lip length for a female is 20 to 22, although we expect the lip to lengthen with age. So her long upper lip is a significant issue for me as a restorative dentist. Her lip mobility measured from repose to full smile is 7 millimeters. That's normal. Her gingival line in relation to horizon. Her gingival line is canted and it goes up and down. So I want you to see that she's got dentoalveolar extrusion with a curved line on her lower anterior teeth. She's got dentoalveolar extrusion on tooth number 7, and she's got a significant cant with wear. So this is a complicated patient. Remember, we have 3 primary treatment options for dentoalveolar extrusion. The first is orthodontic intrusion, the second is functional crown lengthening, and the third is restoring at an increased vertical dimension. So she has uneven gingiva and a cant. The next thing we look at is the length of the maxillary central incisor, and we can see that they're clearly short at 7.5 and 5.5. And the final thing that we look at, can you feel the CEJ and the sulcus? And the answer is yes, you can. So when I go up with my Explorer and feel for the CEJ, I can feel the roughness of the CEJ. So this patient does not have enamel covered by gingiva. She does not have altered passive eruption. So there are the answers to my 5 questions. So the face height is normal. That 3 millimeter isn't an issue, difference between mid and lower third. She has a normal lip mobility, and I can feel the CEJ and the sulcus. So that leads us all to a global diagnosis of long upper lip, dentoalveolar extrusion with wear and a cant, and short teeth. All right, once you make a global diagnosis, now you can make a sequence treatment plan. However, we need more information. In the way that Jeff and I teach diagnosis, the regional diagnoses tell us where the teeth and gingiva go in the patient's face. The global diagnosis tells us where the teeth and gingiva go in the patient's face. The regional diagnoses are all of the other data that you and I have always collected. That's the caries and the wear and the periodontal disease and the endodontics and all of those things. That's all essentially information that we have to have, but it doesn't tell us where the teeth go in the patient's face. So these are all of the regional diagnoses that I collected on Maria. She's got pathologic wear of all of her teeth. She's got erosion on all of her teeth. She's got a significant discrepancy between the fully condylar seated position, for the discussion we're going to call it central relation, and MI or MIP. So she's got a big discrepancy between CR and MIP. And she's got 3 different bite positions. She snores at night. She has defective dentistry. She's got caries, and she's got early periodontal disease. All right, it's important in a patient like this for us to do a risk assessment. And everybody, at least people that teach comprehensive dentistry like Kois and Spear, all teach to do a risk assessment. I'm going to go through a risk assessment based on the way Kois teaches it. And the reason we should do a risk assessment on a patient, because that which has happened in the past is a predictor of what's going to be problematic in the future. And Kois breaks it down into 4 categories. The first is the biomechanical category. And we're going to call it high risk, medium risk, or low risk. And so I think we would all agree that from a biomechanical point of view, she's high risk. And biomechanical means she's got attrition on her teeth, she's got erosion on her teeth, and she's got defective restorations and decay. All of those things make Maria a high risk in the biomechanical category. The next category is functional, and I think we would all agree that Maria has parafunction. And so that makes her also a high-risk patient in the functional category. Periodontally, she's got some early periodontal disease. I do not believe that's going to be the issue for her down the road. So I'm going to say that Maria has a moderate risk in the periodontal category. And finally, dentofacial is Dr. Kois' way of saying aesthetics. And there is no such thing, in my opinion, as a low-risk aesthetics patient if we're doing comprehensive dentistry. They're either moderate risk or they're high risk. And anytime a patient says, I want a beautiful smile, that means to me that they are high risk in the dentofacial risk assessment. So we've now done a risk assessment, and we know what the risks are down the road. I think we're high risk in terms of teeth breaking. We have to acknowledge that she has some caries, and that puts her at higher risk. She certainly, we can't believe that we're going to cure her parafunction by doing this dentistry, and she wants a beautiful smile. So she's a fairly risky patient, in my opinion. All right, so we're now ready to make a treatment plan. We have global diagnoses, we have regional diagnoses. And if you guys were my residents, or if I was at a study club right now in person, we would now break up into groups and we would go through the Socratic method of making a treatment plan. But that's not what we're going to do today because you're not my residents. So there's the answer to the 5 questions that gave us the global diagnosis. There's the global diagnoses. So she has a long upper lip, she's got short teeth, and she's got dentoalveolar extrusion. So let's go through some treatment options for each of these diagnoses. So what's the treatment for a long upper lip? And the answer is a lip shortening surgery. And I think this would be a very legitimate treatment for this patient. A lip lift procedure would shorten her long upper lip and help me as a restorative dentist to get more tooth display. So I think that's a legitimate option for this patient. Short teeth. Obviously, the only real treatment option I have for her is to lengthen the teeth restoratively because we don't need to do crown lengthening. She doesn't even show the gingiva. So the only way I'm going to be able to lengthen her teeth is with restorative dentistry. The third global diagnosis is dentoalveolar extrusion. And remember, we have 3 primary treatment options: functional crown lengthening, restoring an increased vertical emission of occlusion, and orthodontics. Functional crown lengthening isn't going to help me here because I don't have teeth that are so short. I need more retention and resistance for it. So that leaves me with the other 2 primary options that I'm going to use, and that is restoring an increased vertical emission and orthodontic intrusion and leveling. Okay, so now we would be in a good position to make a treatment plan for this patient. And this is what I propose. The first 3 are all the regular things that you and I would do. If we're going to be doing interdisciplinary dentistry on this patient and she's going to go into ortho, we're going to have to put long-term provisional crowns on any teeth that we have questions about that have old crowns on them. We're not going to do ortho on teeth that have questionable crowns. We're going to make lab provisionals and cement them with permanent cement. So all the first three steps are what all of us are going to do normally. So we're going to start this case at step number 4. And I'm going to use a deprogrammer on this patient because she doesn't have a bite. And if I don't know where her bite is, then I don't have a hint how to treatment plan her because I don't know where her teeth fit together when she is in a fully condylar seated position. There are many different deprogrammers available. There are Lucia jigs and they're full coverage appliances. I'm going to use an appliance that Kois teaches. It's called a Kois deprogrammer. And my goal today is not to teach you to use a deprogrammer specifically, but to show you the use of this device in the context of one patient. A deprogrammer essentially takes the teeth out of the mix and allows the muscles to relax and allows the condyles to go into a fully seated condylar position. So with the Kois deprogrammer, it's a maxillary Hawley appliance with a platform. So none of the posterior teeth are touching, only the lower incisors are touching on the platform that sits behind the maxillary anterior teeth. And it is a flat plane, and I'll show you that in a moment. And since we take all the posterior teeth out of occlusion and we're only hitting on 1 or 2 teeth on that flat plane in the front, it allows the muscles to now relax. And as the muscles relax, the mandible can then move on that flat plane into any position it wants to as the condyles go into a fully condylar seated position. So this is what a Kois deprogrammer looks like from the intaglio surface on the left and the occlusal surface on the right. And you'll see there's a shiny flat surface that sits right behind the maxillary central incisors where one lower incisor hits on one spot. No other teeth touch. So now when it's in the mouth, I can mark it with articulating paper and you can see a spot. And she's going to wear this appliance 24/7. She can take it out to eat, but other than that, she has to wear it 24/7. And it generally takes up to a couple of weeks, generally not more than a couple of weeks when a patient has a healthy TMJ apparatus. This doesn't work. We're not going to be using this if we have a patient that's got a medial pole displacement and they have a really sick TMJ. We cannot put a deprogrammer in a patient with significant severe joint disease. This patient does not have that. Hers is only muscle issues. So over time, over those 2 weeks, her muscles are going to deprogram and she's going to move into a position where her condyles are totally seated. How do I know that she's deprogrammed? And the answer is because she keeps hitting in the same spot on the deprogrammer over and over again. So it took her about 2 weeks to completely deprogram. I'm now ready to do a diagnostic mounting on her. Now, why is it important to do a diagnostic mounting? It's important because I don't know if I can restore her in this deprogrammed position. So the beauty of the Kois deprogrammer is that there's nothing covering the occlusal surface. So I can make my jaw relation record with that fast set bite registration material, rigid material, with the Kois deprogrammer in place. I don't have to touch her face. I don't have to manipulate her. She is now in a fully condylar seated position, and all I do is to capture that with a bite registration material. I couple that bite with a face bow, or in my case, with a Kois dentofacial analyzer, which takes the place of the face bow in my practice. I now have everything I need to do a diagnostic mounting on this patient. So there she is in MI, there she is in a deprogrammed position. She's moved significantly from where she was in MI. So I mount the upper cast with the dentofacial analyzer, I mount the lower cast with the jaw relation record, and I now have a very nice representation on the articulator of her upper and lower jaws when her mandible is in a fully condylar seated position. And it was my hope that I would be able to restore her without orthodontics. That was my hope. But once I did the diagnostic mounting, I think we can all see that on the left side, her upper and lower posterior teeth do not oppose each other. She has a significant transverse discrepancy, and her upper and lower teeth are not opposing each other on the left side. Therefore, I can't do crowns on the upper and left posterior teeth, upper and lower left posterior teeth, because they don't oppose each other and are arching. So I did a quick diagnostic wax up to determine my vertical dimension. And there have been a ton of people talking about their ways of determining vertical dimension on all of these webinars over the last 6 months. And I think many of them are way too complicated and commonly, I think, are wrong. So I'm going to quickly tell you what my determinants are for determining a new vertical dimension. The new vertical dimension is not determined chair side. It's not determined clinically, and it's not determined by the posterior teeth. So I'm going to say that again. The vertical dimension is not determined clinically in the patient's mouth. It is not determined by the posterior teeth. The vertical dimension is determined in the laboratory by the person doing the diagnostic wax-up. The vertical dimension is not determined by the posterior teeth or restorative space. the vertical dimension is determined by the anterior teeth. So here are my three determinants, in my opinion, of the new vertical dimension. Number one, anatomically correct anterior teeth. So if the teeth have lost edge due to wear, we're going to lengthen those edges back. If they've lost lingual contour due to wear or erosion, we're going to wax those back. So we're going to make the anterior teeth anatomically correct with wax, upper and lower. The second determinant, the upper and lower anterior teeth must be coupled at a good interincisal angle, which is going to be around 100 to 135 degrees. And the third determinant is a good AP occlusal plane with no step up or step down. So the new vertical dimension is determined by the person doing the diagnostic wax up. It is not determined in the mouth, and it is not determined by the required posterior restorative space. So as a restorative dentist, I don't have to do my own diagnostic wax up, but I better be involved in it with the lab technician, because I'm the one that wants to ultimately be in charge of the vertical dimension. I don't want the lab technician determining that for me. Okay, so what I found when I did this quick diagnostic wax up of those two upper and two lowers to determine my vertical dimension is that at the new vertical dimension that I would be restoring her at, I could not do it because her upper, lower, and posterior teeth on the upper and lower left side do not approximate each other. So this was a bad day. This was a day that I found out that I cannot restore her without orthodontic treatment. Now remember, I'm gathering all of this information before I've ever presented a treatment plan to her, because I didn't know what my treatment plan was going to be until I did my diagnostic mounting. So at this point, I'm now ready to do my DSD smile design. So there's our patient in repose and full smile, and there she is in the sagittal view and at 12 o'clock. So I have everything I need now to send off to the DSD lab to get my diagnostic wax up done. So this is what the actual smile situation was, and this is as they start to frame the smile. This is the proposal. And again, I want you to notice on the left, this is all additive. We're not making those teeth anatomically correct. I'm not adding wax on the linguals of those central incisors to make them correct. This is just additive for the motivational mock-up so she could get a vision of what it would look like in her head. So there we're putting the cast in the 12 o'clock position. The laboratory has now done the motivational mock-up and the wax up and printed the cast. So now you can see this is just additive digital wax on the printed cast that now allows me to do the motivational mock-up in the patient's head. So there's the matrix. There's the bisacral going in, and there it is in her mouth 3 to 4 minutes after we started. So now we make photographs of this, and we show it to her. And I want you to notice that her eyes in the motivational mock-up photograph don't look exactly right, and that's because she's been crying. And she actually had difficulty in stopping to cry. And the reason is because when she looked at those photographs, she said, "Dr. Robbins, this is what I wanted for the last 30 years. I've dreamed that my teeth could look like this. Can you really do this?" And I said, "Yes, I really can. But in order to do this, it's going to take a lot of work." Now remember, when she sees this photograph of herself, she hasn't had a treatment plan presented to her yet. I'm now going to present the treatment plan with these two photographs up on the screen. So again, it puts me in a position that she now has a vision that if she goes through all of the things I'm recommending, that she can have the beautiful smile that I'm showing her. So once again, this is the wax up for the motivational mock-up. However, I can also at the same time order from the laboratory a functional mock-up. And this is a wax up that's done in a traditional way. Now, it's done electronically. It's done digitally. It's not done with wax, obviously, but we're making the teeth anatomically correct. So I want everybody to see the difference. On the left, the motivational mock-up is just additive on the facial. On the right is a functional mock-up that I can use. I could use this in the mouth to make provisionals, and I'm going to use in the mouth to do bonding on her. So in this situation, I'm asking the DSD lab to give me both a motivational mock-up and a functional mock-up.
Hey, Bill?
Yes.
So Becky had a question about what if a patient's teeth and jaws are not amenable to an additive-only wax-up? Can you comment on that?
All right. Well, I've already said the only places that it's not amenable is when the patient is either VME and they've got 7 or 8 millimeters of gingival display, and I can't put my motivational mock-up 7 millimeters up over gingiva and make a 16 millimeter central incisor. So it doesn't work in people with VME. And the second place it doesn't work is in people whose front teeth are already too far forward. Other than that, this will work. This works on everything but those 2 circumstances. Does that answer it?
For me, it does. I hope it does for Becky.
Okay. All right. So it's very important to understand the difference between the motivational wax up and the functional wax up. And I think you can see the models look very different here. So there's the motivational mock-up in the patient's head. There's what they propose to do. We don't need to go up over gingiva because she doesn't show gingiva. So we're going to lengthen these teeth quite a bit restoratively. So what do I have now? I've got an upper and lower cast that has been idealized with wax. But remember, I'm not sending this to the lab in a mounted circumstance. And in fact, I don't want them to wax the upper and lowers together because her upper and lower teeth don't fit together right now. So what I want the laboratory to wax the upper arch and the lower arch independently. In other words, I asked the lab to make the upper arch ideal, the right length, the right occlusal anatomy, the same thing on the lower, but they don't fit together. We've got 2 separate ideal arches. And that's what they did. So now I've got a set of models that are made. Now they look like they fit together here. That's just by the magic of what these guys do to move around the models using a computer screen. But the upper and lower models do not fit together. The upper is idealized, the lower is idealized, but they don't fit together. Now I can use these to go in and do bonding in the patient's mouth. And this is what Bob taught us about a month ago. And I'm going to show you exactly what he taught a month ago in this patient. So the beauty of doing this digitally is I could ask the laboratory to make me a set of printed casts with the complete diagnostic wax up on the upper and the complete diagnostic wax up on the lower. And that's what you see on the left. That's a set of casts with the complete wax up. I could then say, I want you to remove the digital wax off of the posterior teeth on upper and lower arches and print me another set of casts with just the anterior diagnostic wax up. And now I've got 2 different sets of casts that I'm going to use on this patient to do her whole mouth and composite prior to the ortho. All right, so once again, on the other side, we've got complete diagnostic wax up, and we've got diagnostic wax up of only maxillary and mandibular anterior teeth. So we're going to make a matrix out of a clear matrix material on the wax up of just the front teeth, because I'm going to use this matrix to do direct bonding in the patient's mouth. So what we're going to do is we're going to make the upper and lower 6 anterior teeth anatomically correct using direct composite in the mouth. We're then going to come back and put indirect composite on the posterior teeth and make them anatomically correct. And in order for me to have a matrix that fits in the mouth, it has to fit over the posterior teeth as they are in her mouth. That's the reason we made a matrix off of these casts. So I've now got a clear matrix that was made off of these casts with anatomically correct front teeth, but posterior teeth as they are in the patient's mouth. So this matrix will now very nicely fit in the patient's mouth. So I'm now ready to do my direct bonding. So I put my composite in a composite heater, and I'm going to do these one at a time. Just as Bob showed us, one technique to do this. I'm going to isolate one central incisor by putting the Teflon tape on the adjacent teeth. I'm going to edge prime and bond. I'm going to put my heated composite into the matrix and seat it and light cure it. After it's light cured, I'm going to finish it down. Now in this case, I'm going to leave a diastema between 8 and 9 because I believe it looked better. But you'll see on all the other teeth, there's no spacing. So you don't have to, when you do this direct bonding, certainly it doesn't require that you leave a space. I just wanted a space because I liked it with the height to width ratio of these teeth. So I'm going to finish that one down, and then I'm going to go back and do the next one. And over the period of the morning, I'm going to do direct bonding on 6 through 11 and 22 through 27. So here she is at the end of the morning. I am no great bonder. I'll never even come close to Marcos or Bob in bonding. So I am a mediocre composite guy at best. But the point is that everybody can do this. This is not complicated to do. It just takes time and patience to do it. All right, so that took me the morning to do that. So we're going to get the patient a smoothie. She's going to relax for 30 or 40 minutes. I'm going to have lunch. And then we're going to come back in the afternoon and we're going to do the back teeth. Now, there's a number of ways you can do the back teeth. Bob showed a cool way where he put little islands in and he direct bonded those. I think it's very difficult to do direct bonding in the posterior part of the mouth because the teeth have to be separated. Obviously, we can't have this as one unit in the back of the mouth because this patient's going into ortho. So I prefer to do this indirectly, although it could be done directly in the mouth. So I'm going to make a second set of matrices for indirect bonding. And I'm going to actually make these overlays, composite overlays myself in the laboratory the day before. So I've got a matrix that I made off of the complete diagnostic wax up, and I can now lubricate this set of casts. I can put composite into the matrix and seed it over this cast to make indirect restoration. And that's what I'm showing you here. So I'm going to now pop that off. I'm going to separate those and polish them, and I'm going to make composite overlays. Bob also showed a way of doing this where we can do it with a Mach 2, I guess it was called, made by Parkell. I don't know if it's still Mach 2, but it is a material that is rubberish. It's a PVS material rather than this stone cast. So there's many variations on this theme. So I just made these overlays in the lab the day before, and I'm going to now bond them into the mouth. The more common sense way to do this is by having a lab do it for you. So I did it myself just because I didn't have a case and I wanted to do a case that way, but this is the way we normally do it. We normally just have the lab make PMMA overlays. They mill these overlays, and I get them back from the lab. I aerabrate the inner surfaces of them, and I bond them into the mouth. So this was a patient that we were doing pre-orthodontic bonding on with PMMA overlays. So you can do it directly in the mouth. You can do it indirectly, making them yourselves, or you can do it indirectly, having the lab make the overlays for you. All right, so I'm now ready in the afternoon to bond these into the mouth. I'm going to put them on one at a time because I don't want to get these stuck together. I want them to be individual at the end, and I want them to be well done because these may actually become definitive restorations for this patient. In other words, she may stick with these for many, many years. More about that in a few moments. So there we are after one of the arches has been bonded, and there she is done. So that's where we started in the morning, and that's where we finished in the afternoon. So now she's got 28 units. We've done a full mouth rehab and composite in a day. So that's where she started in the morning, and that's where we finished in the afternoon. Once again, lower arch the same. And there she is before and after. And she's tired, but she thinks this is the coolest thing ever because this is the first time she's had teeth as long as she can remember in her adult life. And so I tell her, you know, Maria, I'm so glad that you're enjoying these teeth. Enjoy them tonight because tomorrow, this is what happens. So she goes to the orthodontist the next day and gets started with ortho. Remember, the upper and lower teeth were not designed to have good occlusion. They were designed ideally. Our goal was to make the upper and lower anterior teeth anatomically correct. It is no longer my problem. This now becomes the problem of the orthodontist to make those anatomically correct anterior and posterior teeth fit together. And I say that in a joking way, but again, this is my orthodontist, Tito Norris, that I work with, and we don't do cases anymore where patients in ortho without pre-orthodontic bonding. So if it's 28 teeth, if the patient's going to get a full mouth rehab at the end of ortho, they're going to get 28 units before the ortho begins or during the ortho. If it's 6 or 8 upper anterior teeth, they're going to get that done either before or during the ortho because that's the only way he knows how to move the teeth into the correct position. So this is just progress photos on what Dr. Norris is doing. Opening a space, she required an extra space for an implant on the lower left side to make all of this work out. She's now a little more than 12 months into ortho, and at this point, we're starting to get relatively close to the end. Now, we're never going to get out of crossbite on the right side, but that doesn't matter to me. I can absolutely, that's going to be better than it is there, but I can certainly restore that patient in crossbite as long as I've got good anterior guidance. But the big difference is going to be on the left side because now we're going to have upper and lower teeth opposing each other so that I can do restorative dentistry tooth against tooth. So in a brief sort of hour and a half, I gave you guys an overview of what DSD has to offer us. It doesn't have to be with Coachman's DSD system, although I think it's a wonderful way to do it. You can also do this with your own local lab as long as you know what you want and you're able to educate them on how to get there. So in closing, I want to first of all thank Coachman. I want to thank him first of all for his innovation and secondly for his friendship. He really is a wonderful guy. The other people I want to thank are my ACU family. And everybody knows Bob Margis, and everybody loves Bob Margis. And everybody knows Kirk Barrett, and everybody loves Kirk Barrett. Almost nobody knows Barrett Straub. And you should know him, and you should love him because he's the one that makes all this work. So the rest of us show up and talk, and Barrett is the one day after day that gets the work done for ACU. So I don't think anybody's had an opportunity to really thank you the way you should publicly. So Barrett, thanks so much for all that you do for ACU.
Oh, thanks, Bill. Absolutely my pleasure. I appreciate that.
So you guys, remarkable things can emerge from a feeling of fresh possibility. And that really goes two ways today for me. First of all, for DSD, because it has brought a feeling of fresh possibility to me. And secondly, through ACU, because all of the things that I learn week after week through ACU give me a feeling of fresh possibilities also. So thank everybody for showing up today, for being a part of ACU, and for listening to my little story today. And thanks to my three brothers for helping make all this happen. So I'm open to questions for a few minutes if we have any.
Awesome job, buddy. Awesome.
Bill, there was one question that came from a couple different people, and it was regarding how you decide to fee or charge the motivational mock-up with a patient, a new patient, or even existing patient.
Yeah, it's a great question, Darren. So I would say there's essentially 3 ways to do it. Let's just say, for the sake of discussion, that the DSD mock-up and Smile Design is going to cost $500. That's a significant amount of money. So one way to do it is to tell the patient, Mrs. Jones, I'm so excited that you're here, and I've got a vision in my mind of what your smile could look like if you gave me the opportunity to help you with that. However, I know you don't have that vision, and I've got a way of giving it to you. I can take some photographs and send them to a lab, and they can make some materials that I can put in your mouth and give you a very close representation of what it would look like if you decided to proceed with treatment. Would you like to do that? And 100% of the time, the patient's going to say, God, I would love that. The first thing you can say is, the fee for that's $500. Your investment's $500. And I know it's a significant amount of money, but I think it will be worth it because it will give you a view of what the possibilities are. That's one way to do it. The second way to do it is to say the same thing I just said and then add at the end, and if you decide to proceed with treatment, then we will deduct that $500 from the overall fee. And that's what most dentists do. Most dentists charge the patient for the DSD mock-up and then credit it if they decide to go through a treatment. The third way to do it is to not even bring money up and not charge them. And that's what I do. I'm a little different place in my life, obviously. I'm not a young dentist with a lot of debt. And for me, doing a DSD motivational mock-up is a marketing tool as well as an educational tool. And even if a patient chose not to go through with treatment, they would have the pre and post-op photographs that they would show to their friends. And so I've made a decision that I'm only going to do this on patients that I believe there's a reasonably good chance they're going to say yes on. And if they don't, I'm going to mark it up as a marketing fee. So I don't charge for it. I give it as a gift, and I do it the second appointment, and it's at that time that I start talking about the treatment plan.
I'm glad you described it that way, because I think the point is that you get to do it any way you want. As Kirk says, there's no laws here. We get to decide how you want to do it in your own practice. And it might be different for each patient. Like you said, if you got somebody who you know is going through with it, or that's been a long time patient or something like that. But what I would say is it makes what we do so much more predictable and so much easier that the time it saves me and the agony and the predictability that it brings, I'm happy to do just what you do, Bill, and not even bring it up as a fee. In the back of my mind, when I'm feeing out the case, when they say yes, I'm putting that back into it, so I know I'm going to get paid for it. And the cases that don't go forward right away, okay, that was marketing, and I like it that way. Someone asked about, do you include your own time? It hardly takes any of our time to get the records, so you're doing those records anyway as part of the comprehensive new patient exam or whatever. So I agree. I think you described it really well.
Yeah, thanks. The other thing is, it's always an exciting day in the office when we do a motivational mock-up. I don't do them all the time. Again, I'm not that busy. I'm not doing a motivational mock-up every week. So when I get to do one, it's an exciting time in the office. Everybody knows we're getting ready to do one. We know the patient's going to love it. It's just it just breathes energy into the practice to do this.
Yeah, I agree totally. Actually, I saw a patient this morning who came in, new patient, found me on Google, which never happens, and wanted veneers. He says, I want veneers. And I took one look at him, and he's got pretty big teeth, but big spaces. And he wants to close the spaces with veneers. And I'm going, well, there's no way. Your teeth are going to look like giant horse teeth. So we're going to use the motivate. He's like, and I'm not doing ortho. He needs ortho. We're going to use the motivational mock-up as a way of helping him understand what would happen if we just close the spaces by making his teeth bigger. So it really becomes a powerful tool.
Yeah, your point about ortho is a really good one. Almost all these patients need ortho. Let's just put it out. Most comprehensive wear patients, most of the patients that come in needing interdisciplinary dentistry in my practice need ortho. And when I present ortho to a patient, nobody wants ortho. No adult wants to have braces or even Invisalign. Nobody wants ortho. So when a patient says no to ortho to me, it goes in one ear and out the other. It has no meaning to me. Now I know it is my obligation to help the patient understand why they have to have ortho. So do not be put off when a patient says, I don't want braces. I don't want braces either. But you can't have what I show you in that photograph if you don't have braces. That's why the motivational mock-up is so powerful.
Yeah, totally agree with that.
You know, Bill, something you said that resonated with me was with that one gentleman was you put that mock-up picture as the vision to hold as he goes through the process.
Right.
And, you know, what a great tool to, you know, when the adult is going through ortho and not having fun per se, we have this vision to say, this is where we're going. Remember, this is where we're going. I'm also curious if you find that there are some patients that go through that process and maybe don't accept it right away, but they have that picture, and 6 months, a year, 2 years, do you find people come back and say, I've been looking at this darn picture and I want that now? Or do you find that when done well, they accept right away?
Yeah, I mean, it's a great question. The problem is I don't have a ton of these cases. I probably only have 20. So I'm no world-class DSD guy. And most of the patients I presented this to have said yes. I think I've had 2 that have surprised me out of 20 that have said not at this time. And at this point, neither of them have come back and had it done. So I think it is reasonable to assume that with that picture on the refrigerator, there is a point down the road where one might come back and say yes. So for sure, I like the idea of those photographs being out there in the world, for sure.
Yeah, Barrett, I can tell you, because we've been doing this not with Coachman's product, just with our own lab for 15 years, 20 years. And yes, I have many times where patients come back a year, 2 years later and say, remember that thing we talked about? Can we talk about that again? I'm in a different place, or now I'm ready, or whatever. So I do think that happens.
Sure. Some life circumstance, all it takes is one life circumstance to change a patient's opinions on some of this stuff.
Hey, Bill, you know I've asked this question a million times. Has there ever been a more fun time to be a dentist?
Oh, God. I'm telling you, for the young dentist in the crowd, it's a difficult time to be a dentist. There's no question about that. And it's only gotten more difficult in the last 6 months. But there's never been a better time to be a dentist with the techniques that are available to us today and the technology that's available to us today. As some of you know, my son is a second-year dental student, and he's actually living at home. And so I get to see him a lot. We have dinner together a lot. We talk a lot about what I'm doing and what the possibilities are for him. And I mean, in a lot of ways, I really envy what's ahead of him. Now, there's parts of it I don't envy, obviously. But I do, in a lot of ways, envy what's ahead of him because it is a magic time to be a dentist. There's never been a better time than today, for sure.
So fun. Great job, man. Great job.
Yes.
Any other questions from the ACTU members? Anyone? Darren, are you working on patients today? What are you doing?
I did. I saw patients all morning, and even had an emergency right when we started. A broken tooth came in.
Yeah.
Yeah, I was out last week at Pankey Masters Week. You were there.
Yeah.
And we so I needed to make up some time, so I worked today.
Yeah. Hey, I do have a question, Bill. Like, what do you see on the horizon just in the short term, just with digital dentistry? Like, I mean, because you get to talk to a lot of key opinion leaders. What are you most excited about when you look at the next year or 2 years? What great restorative dentists are going to be able to do?
Well, for me, I think the next exciting part is the virtual articulator. I mean, the rest of this we've got. You know, everything I've showed has become that I've shown today has become very routine. I mean, there's nothing gee whiz about it really anymore. So I think the next cool part is the facial recognition software is obviously a cool thing that's now here. And then being able to do the virtual articulator is the next thing. And there's certainly devices now that are available to help us get good jaw relation records and movements. It's expensive technology right now, but it's not going to be that long before all of the things that we had to do analog with a face bow and a pantographic tracer and check bites and all of that stuff is going to be easy to have. So it's going to make our dentistry better. So I think that's what I'm really excited about. And the next step is what's going to happen on the instrumentation side.
Love it. Love it. Cool. Well,
Yeah, we talked on the front end about, the benefits of virtual and where this future is going and where the ActU can kind of fit a need in dentistry. And let's talk about our community feature that we're getting off the ground. I think one of the selling points of VIEW, it makes us special, is we have a fantastic faculty, world class. You see a couple of them, in front of us here, and this is going to evolve to be a pretty impressive study club with quality clinicians from all over the world learning from the masters. And, Bill, I don't know if you mentioned it last week, I wasn't on the master class, but we're kind of launching a community feature where, we want your questions and we want to learn from one another. I mean, our avatar subscriber, our member, is lifelong learners. We're all lifelong learners, and we want to learn from each other. And so, Bill, why don't you kind of discuss our community feature and what we want to see that grow into, please?
Yeah, thanks, Barrett. So one of our goals is to, and when I say we, it's Bob and Kurt and Barrett and I. So we're the four people that put together this idea of ACT University. And our goal is to do more than just present a speaker every Friday. Although in itself, I think there's no place you can go on earth and get the quality of speakers that we provided for you for the cost of a membership. But really what we want to do is more than that. We want to create a community of like-minded individuals from all over the world is our goal. And so we've set up a community page, and Bob and I are going to sort of be the page masters of that. And the goal is that we create a way to communicate with the members of the community and the masters that have given the programs. So the goal is not that you would send a case in and say, how do I treat this case? That's not the purpose of this community page. The purpose is to communicate about what's going on in your practice related to the people that have spoken as the masters. And so Bob and I will sort of be liaisons between you and the masters that have given presentations, and it will be a way to continue a dialogue after the master presentation. In other words, if you want to speak to me about something related to this, then you just put a note on the ACT community page and I'll answer it. Or if you want to ask a question to Dr. Bacow about her presentation last week, then I will be the one to facilitate that discussion between you and Dr. Bacow. So our goal is to create a community, more than just people that you sit and listen. We want you to be more active and to be involved in the learning. So that's the goal. You want to add anything to that, Bob or Kurt or Barrett?
Yeah, so starting next week, you'll see all of us kind of show up slowly. And what's really happened, this has been so fun to watch this community grow. And even ACT Dental went through this. We did the COVID conference, and then we had to go back to work, because we actually had jobs in that whole time and clients to service. And now that we've got our feet back underneath us and got our clients really well taken care of on the coaching side of things, and ActU has taken off, and we're ready to get back to really building and nourishing this community. So I'm just going to encourage you next week, or even I think after this, Angela, you'll send out a notification of this somehow where you guys will all be, you'll be notified on how to do that. But when you go back and start looking at the classes or the courses on ACT Dental U, you'll be able to see the community feature back there, and you can just add questions. So chime in, add your suggestions, even cool things that you see. So you're going to be surrounded by a lot of people that are just here to help you. And like I've shared from the beginning, dentistry is just an incredibly noble profession. There's one thing I've been grateful for my entire career, and it showed up even more on March 18th, was we got a pretty cool group of people here. This is a darn cool profession that I was blessed enough to fall into. And it's amazing when you reach out and ask for help, how willing all the others are, willing to do that. So that's what community is all about. The content is, I agree with you, Bill. You're not going to find better speakers and better content anywhere in dentistry, but community is what people are going to stay for long term. And we're just so grateful to have you guys here. The relationships mean the world to us, and you guys being a member of Act Dental U means the world to us. So you'll see more and more. We're going to keep adding features and more things to provide more value. So don't be afraid to tell your friends and keep showing up for Act Dental U. Bill, do you want to talk about next week? And who we have speaking next week?
No.
Wait, who do
Next week we have Nate Lawson.
Oh, Nate Lawson. No, I'll do Nate Lawson. No, let me do it. Okay, so wait, I'll do Nate. Obviously, if you guys are watching this right now, I don't have the schedule in front of me because I got a bunch of other things. But Nate Lawson, now here's what I just interviewed him again this week, and I just want to say this. He's one of those guys that's taken a very important subject and made it very interesting. So I put him in the category of like a Zversky who took, he took pathology, made it funny. You got Viola who made pharmacology funny. Bill, who makes restorative dentistry very, very interesting. I put Nate Lawson in that career. He's going to have a very long career as an awesome educator. He has 50,000 followers on Instagram. 50,000. And he interviews the top material guys in the world. And so we're going to be talking about biomaterials next week. And I know you're going to find this fascinating. So I just interviewed him this week. I'm like, what does a biomaterials guy do? And it was one of my favorite. So he's going to be...
Let me say one more thing about
go ahead.
it. So through the years, my go-to guy for dental materials is my good friend, John Burgess. I actually worked with John in the Air Force many years ago, and I taught with him at the dental school many years ago. And he was the guy I could always go to and find out about anything related to dental materials. And John's retired, and Nate took over his position at University of Alabama. So Nate is the next in line of a handful of world-class dental materials people that have become the go-to guys. So for me, the baton has now been passed from John to Nate. And I agree with you. He is one of 2 or 3 of the best young dental materials people on earth. And it's a good thing we own him in the United States. He's at the University of Alabama right now. So he will be great. Another thing, I mentioned Tito Norris, my orthodontist, who is a world-class orthodontist. I feel so blessed to work with him. He's doing a master class for us on October 23rd. So we got a bunch of cool stuff coming up. So it's only getting better. It's only getting better, for sure.
Yeah, I got to pile on Nate. One thing I noticed when I was talking to him this week, the guy has an incredible heart as a teacher. You'll see this. You'll just see it come out. I know you'll absolutely love it. And I do want to say this about Tito. I did not know Tito before the COVID conference, but some of the best comments we got from all the speakers came from his presentations. They are life-changing. So highly encourage you to watch Tito also. You will love that.
Yeah, and just a couple more thank yous. You see Darren Becker here. He's been with us since the very beginning. He's one of our faculty. You're going to see a lot more of him. He's got a master class coming on, and he's just great to have around. So thanks, Darren. And then, Bill said I do all the work, but actually it's Angela below me here on the screen who actually does.
Yeah, for sure.
I'm a really good delegator. So Angela actually makes this happen. So, and she's just fantastic to work with. So thank you, Angela.
Thanks, Barrett. It's fun. I learn a lot.
Good.
All right, you guys.
Well, cool. That's all.
We got Labor Day, so we get to say Happy Labor Day next Friday, so we're going to say it today. So thanks, everybody, for coming. I really appreciate anytime people choose to come and listen to me speak. I feel honored by it. So thhanks for coming, and thanks for my brothers from ACT for letting me have the stage today.
You got it. So
Thank
hug
you,
on those
Bill.
grandkids. Give your wife our best. And that's all for us this week from Act Dental U. We'll be back next week with an amazing speaker, the week after that, the week after that, the week after that. So keep showing up, and we're going to bring you some great stuff. You guys enjoy the rest of your day and enjoy your weekend.